So I'll be discussing what it takes to establish and grow a successful, responsible organization. And this is a picture of a patient who had cataracts and had a cataract surgery. Unfortunately, this was the outcome of his cataract surgery. And you can see here that ultimately that cataract surgery was not successful. This was a cataract patient who did not come through Unite for Sight. Instead, it was actually a patient who was seen by one of our partner eye clinics years after he had had this very poorly done cataract surgery. But many organizations would count this particular patient as one of their numbers, with a patient who had cataract surgery, and oftentimes people would assume that he had successful cataract surgery and was able to then see. But here you can see that he ultimately had a very, very poor outcome, which really demonstrates and pinpoints the importance of measuring outcomes and not outputs. So this particular patient's output would be, he was one of the cataract patients who had cataract surgery, but his outcome was that he ultimately became permanently blind because he had an infection that was caused by a poorly done cataract surgery, also by a team of doctors who had come in very briefly to the country, provided the surgery, and provided no follow-up care. So ultimately, when he then had an infection in his eye, there was nothing that could be done for him. He didn't know where to go or what doctor to see, even though there were indeed doctors in the country. He just was not connected to them. And similarly, there's oftentimes, and you've probably seen various types of organizations that really focus on outputs. There's a lot of organizations, for example, that count how many malaria nets were distributed. And this, for example, is an example of a meter on a malaria net organization. But many times, the malaria nets are not actually being used to eliminate or reduce malaria. Here you can see it's being used as a fishing net. Here it's covering a garden. Here it's a soccer goal. Here it's just covering food. And so you can see that even though this particular organization and many organizations distribute malaria nets, if you're just looking at the outputs, you would know how many malaria nets are being distributed. But you need to know whether that distribution of the malaria nets is indeed helpful and beneficial to the communities. So if they're just being used as fishing nets or being used as soccer goals, obviously that's not being used for the intended purpose. And they're being used in these ways because when they're just distributing and not actually working with the community to make sure they know what to do with those malaria nets, the people think, well, this looks like a fishing net, so then they use it as a fishing net, or it looks like it could be used as a soccer goal. And when you think about it also as the fishing net issue, a lot of them have the insecticides. So then if they're laying out their fish on the fishing net on the beach, for example, and then just to dry it, then the fish are then getting contaminated with those insecticides. So then it can even cause harm. So that's why it's so critical to assess when malaria nets or any other type of product is being distributed, is it indeed having the intended purpose? And there's an organization called Play Pumps, and many of you may have heard about Play Pumps, especially back in 2005 and 2006. There was huge hype about Play Pumps. People were very, very excited about this very innovative idea. And the goal was that children would play on this play pump, and water would then be pumped up from the ground into the tank that's on the top of the picture. And that would be a great way, they said, to be able to collect water for the communities. And here you can see kind of the diagram of how the play pump was intended to work. This was the ultimate outcome of the play pumps. The children were not playing on the play pump, so it was not generating this. It was supposed to be like a merry-go-round, but no one was actually utilizing that. But the Play Pumps organization actually went into the communities, removed their traditional pumps that had actually been working well, replaced it with these play pumps, and then they had no way of getting water except by using the play pumps. So without children then using the play pumps as intended, and here you can see they're just kind of sitting on the play pump, it ultimately ended up being women, and especially older women, who were in charge in the communities of getting the water. Instead of using their traditional pump, they ended up having to go around and around on these play pumps just trying to get water. And you can see here as well, this woman says, from this your arms start to hurt. And interestingly, PBS actually had done the first video back in around 2005, 2006, very, very excited about this amazing, innovative idea of play pumps. And then a few years later, they actually went back to the communities, and this is what they found, and this is actually from a video that's online, and you can see the link there. Then they found that the play pumps were not working as intended, and the community members, instead of having better access to water, it actually removed their access to water. So in addition to having the women having to go around and around, they also had a lot of play pumps that were breaking down, and there was no way for them to get any type of fix on that because there were no local maintenance workers, and there was also no follow-up or continuity of connections with the communities. So many of them were just breaking down. And this, for example, you can see the child is trying to get water, but it's not actually working. And this is a picture of the traditional water pump that was ultimately removed from so many of these communities. So Bill Clinton actually was one of the ones who was really excited about this idea, and it is innovative. It's something that people had not thought about before. The merry-go-round is not just a simple piece of playground equipment, it's a play pump water system. Lack of access to clean water is one of Africa's biggest health challenges. How can we spread wonderful innovations like that? Last week, we announced a partnership with the U.S. government and the Case Foundation to install 4,000 water pumps in 10 African nations, bringing clean water to as many as 10 million people. That same spirit of innovation is showing up in other public-private collaborations. And play pumps had focused very much, again, on outputs. How many communities could they install these play pumps in, as opposed to thinking about outcomes and how they could actually improve the water system. And you can see here they were very focused. They wanted 4,000 play pumps to be installed very, very quickly. And UNICEF then, a few years later, actually did an evaluation to determine if they should become involved with the play pump process as well. And they actually found there were health issues. There a lot of dizziness from this kind of merry-go-round. Children were falling off and hurting themselves, which of course would make the problem worse, and they were actually vomiting after spinning. And they said also when children are not available, adults, especially women, have no choice but to be the ones to use this play pump. And they also found that a lot of the women were embarrassed to be using this play pump because it was seen as a child device, as a merry-go-round, and they were ultimately forced to have to do that just in order to get the water for their families and for the community, but they found that to be very, very embarrassing. UNICEF also found that 63% of Zambia play pump sites reported that they were not consulted, presented with no technology choice, and preferred the previous hand pump that was removed, which really pinpoints the importance of working with local communities and not making assumptions of what a community needs, but instead determining with local professionals and local community members how best that a particular organization can support and assist those local communities. There's an organization, a terrific organization called Kickstart, and they, for example, described that they could base our claims of success on the number of pumps we've sold to date, but this tells us nothing about whether we are meeting our mission, helping people get out of poverty. To know this, we have to measure how much more money the buyers of our technologies earn as a result of owning them. And this is, you can see kind of the great disparity between Kickstart, which really focuses on outcomes, as opposed to play pumps, which was very, very focused on just how many play pumps they could distribute. And ultimately, by around 2010 or 2011, play pumps actually dissolved. They are no longer in existence because they realized and came to the attention of the public that despite the millions and millions of dollars that were invested into the organization, they were failing and not able to provide quality water to those communities that they were working in, and actually had made things much, much worse for those communities. And perhaps if they had taken a different stance, much more similar to Kickstart, for example, where they were focusing more on outcomes from the onset and not just an immediate kind of evolution where play pumps wanted to focus on just installing 4,000 pumps immediately, as opposed to growing much more organically and making sure that they were helping those communities and evaluating before they continued to reach more and more of those communities. So Kickstart provides a variety of different types of technologies, water pumps as well as cooking oil presses that they then sell to local community members, and those community members are then able to establish businesses. And Kickstart then has all of the buyers of their different products fill out forms, which then creates a database for them so that they can then follow up with those community members and ensure that those community members indeed have been able to start businesses, that the technologies are continuing to work, and that they have generated improved income due to their purchase of those Kickstart technologies. Unite for Sight similarly focuses very, very heavily on outcomes and not just outputs. We could, for example, just say, a blanket statement, how many cataract surgeries that we've supported and sponsored, or how many patients have received eye care. But we always collect and analyze data to make sure that each of the cataract surgeries provided by the local eye doctors that we work with have indeed restored the sight, so that we know that there are no patients who are receiving care who are ultimately like that patient at the very start of my presentation. Unite for Sight's programs work with local eye clinic partners. We have programs in Ghana, Honduras, and India that support and assist local doctors and their social ventures to reach patients who are the hardest to reach patients living in extreme poverty in villages, refugee camps, and slums. So the process that we utilize when we are working with those local eye clinic partners is we collect data from every patient who has been seen by the local doctors. They, for example, have a netbook and an Excel document that they record all of the medical records for each of those patients, which is very important so that the local doctors are able to then review those medical records as needed for their own patients. But then that also enables us to analyze the data for the clinics so that they know the exact breakdown of different eye conditions in their local communities and how best they can then reach more and more of the patients. We also, for every cataract surgery or every other type of surgery that's provided, most of them being cataract surgeries, we require from the clinics the preoperative and the postoperative visual acuity data, which we then analyze to make sure that, yes, indeed, each of those surgeries, it's not just a cataract surgery, it is a sight-restoring cataract surgery. And we also work with a lot of volunteers, especially student volunteers, on IRB-approved research studies, which then enables us and our local eye clinic partners to further understand barriers that are impacting those hardest to reach patients. And that's what it then enables our organization and our local partner eye clinics to grow and expand and reach more and more of those patients on an annual basis. So just as a quick overview of how the Unite for Sight outreach programs work, we partner with existing eye clinics. They had been in existence for years before we started working with them, and they were providing care for their regular private paying patients. So patients who didn't have specific barriers that were impacting them, they knew that they could receive eye care, they knew they could transport themselves to receive care, they could finance their own care. So the clinics we work with continue to provide the care for that division of the patients, which then enables each clinic to be self-sustaining, and they can then purchase their operating equipment, maintain their building, maintain their staff, and enable them to have that self-sustaining clinic. And then additionally and concurrently, Unite for Sight develops with them an outreach program, providing them with infrastructure so that every day all throughout the year, their clinic can also go into these villages that are located 1 to 8 hours away from that local clinic. The local doctors then provide comprehensive eye care. So if a patient needs medication, they receive medication. If they need glasses, they receive glasses. If they need surgery, they're transported back to the clinic, so again, 1 to 8 hours or so away, and then the local ophthalmologist provides them with surgery, and then they return to the village. And each of the clinics then return to each of those villages on a monthly basis. So if they went to Village A today, they'll go back to Village A around January 6th and around February 6th, so that each of those villages and each of the patients have access to continuity of care. So this is an example of some outreaches in a village in India. And all the medication and supplies are procured locally, which enables then, the local clinics to be sustainable and not reliant, for example, on only donated supplies, which may or may not be accessible. We also utilize community eye health workers, which are local village personnel who are then trained and understand how a cataract surgery, for example, occurs. And they're then able to provide on a peer-to-peer level with their local community members what happens during a cataract surgery, or why a particular patient who may be fearful of receiving eye care, why they should come to this particular outreach in their village to receive that care. And they also help to identify the hardest to reach patients, maybe bedridden patients or patients whose families don't want them to receive medical care. And they make sure that those particular patients know about the outreaches and hopefully can then come during a particular month. The Unite for Sight outreach team is locally led and managed on a daily, annual, monthly basis all throughout the year by the local doctors. And we also have a lot of volunteers, both students and professionals, who support and assist the local doctors with all of the non-medical care. So they can help with patient intake, patient education, visual acuity testing, which then enables each of those local doctors to be able to examine and diagnose and treat about 100 to 300 patients every day, simply because they're able to focus on what they know best and what they're trained to do, which is the medical care, and all of the other aspects can then be done by the local volunteers, or by the visiting volunteers. And those volunteers also concurrently are able to learn from those local doctors about how to reach those hardest to reach patients and how best to pursue public health and eliminate barriers to care for the patients who are not able to access and afford the care. So here you can see a picture of one of the outreach teams with some of the visiting volunteers and the local doctors. The outreach begins with an educational talk by the local optometrist or ophthalmic nurse. And here you can see another of the photos. Patient intake, as I mentioned, is done on the netbook, which then creates the database that we can then analyze for the clinics. There's an outreach vehicle that's utilized by each of the clinics that can then go into these villages, transport the team to the village every day. And here you can see one of the visiting volunteers as well as the driver who is then doing the testing of visual acuity. The programs also engage local volunteers. In addition to the community eye health workers, there are also more informal volunteers who assist and support. Oftentimes they or their family members have been impacted by the Unite for Sight outreach programs, and they want to then contribute to being able to help with their community as the outreach team arrives each month. Then the ophthalmic nurse or the optometrist examines the patient, and from the Excel database that we analyze for the clinics with all of those medical records, then each of the clinics can see the breakdown of the diagnoses, as well as a lot of other information, female to male ratios, for example, and a whole slew of different types of analysis that is done. But you can see here it's about 25% of the patients that are being diagnosed have cataracts. And there are a lot of other conditions as well, which are all treated. There's the comprehensive care that's provided. So anyone who needs advanced ophthalmic care, such as cataract surgery, is transported back to the clinic, and that's where they receive their surgery. So through these programs, Unite for Sight and our partners have provided eye care to 1.7 million patients, including 75,000 sight-restoring surgeries since we began as a very, very small organization, our first international programs back in 2005. And we work with amazing local doctors who are so genuinely dedicated and passionate to provide care for those patients living in villages. And Dr. Seth Wanye is one of our partners. He's been the only ophthalmologist for 2 million patients in the entire northern region of Ghana since he began working there in 2004. When he first arrived in Tamale, he wasn't able to provide any cataract surgeries because he actually didn't have the operating equipment to do so. He was in a government hospital and just had no equipment. And in addition to that, the patients were not able to afford the care. So he actually drove then 10 hours back to the capital just to do cataract surgeries with his colleagues in order to keep up his skills. We partnered with him in 2005, and you can see here the growth and evolution of our programs with him. He began by providing about 300, 400, 500 cataract surgeries in a year, and in 2012, he provided over 4,200 cataract surgeries, just him, and all of them sight restoring, and the patients went from being completely blind to having their sight entirely restored. And it's truly such an honor and privilege to have the opportunity to work with such amazing local doctors, and he's developed these programs to reach those hard to reach patients by developing strategies that he knows works best in his local communities. And he and his team provided comprehensive eye care in just 1 year in 2012 to 70,000 patients, which is a remarkable number. You can see a few of our other graphs here. Crystal Eye Clinic is another of our partners, providing more than 2,500 cataract surgeries each year and more than 45,000 patients in each village. And we work with 5 eye clinic partners in Ghana, 3 in India, and 1 in Honduras. And it's through these programs that are through these sight restoring surgeries with our partners that they've provided just in Ghana alone in 2012, it was 9,075 of these sight restoring surgeries. And in the entire country with 45 ophthalmologists, the 4 of Unite for Sight's partners, which is about 9% of the ophthalmologists, actually provided 50% of all of the cataract surgeries done in the entire country. And that was because our support enabled them to build that local capacity and reach so many patients who are in need. So Unite for Sight's healthcare delivery solution very much focuses on supporting the local doctors and enabling them to build their local capacity to reach the patients. And just to conclude, we also have a lot of IRB-approved research studies that are pursued, which enables those local doctors to then understand the barriers that are impacting even the hardest to reach patients, maybe the barriers that even those local doctors are not aware of or familiar with. And it's through those IRB research studies that the local doctors can develop new strategies and new educational methods so that the patients who are not coming to outreaches each month or each time the outreach team visits in a month, they can then develop these new types of strategies to reach them. And as an example, there's a study that we've been working with a number of our partners across many of our the country locations to understand why are a lot of the adults arriving and coming to receive eye care, but many of them have children in their household, and why are they not just bringing the children along with them to receive eye care since they're coming as adults? And it's through those types of studies that the local doctors can then understand that type of barrier, that why are not enough children coming just for a regular checkup, because even if the children are not complaining of a particular eye condition, many of them do have underlying eye conditions. So that's a way that they're then working to reach more and more of those children as well. So that concludes my presentation. Thank you so much.